Today I will be discussing screening algorithms for cervical cancer. So in my presentation, I will be covering preferred methods for cervical cancer screening, the basic principles for various guidelines, specific cervical cancer screening guidelines, among which I will be laying stress on the FOGSI 2020 guidelines, which are more relevant to Indian context, and among the global guidelines, I will be covering WHO and the American Cancer Society guidelines for cervical cancer screening. So, cervical cancer screening, we all know, is the most successful cancer screening program worldwide. And we know why, because of the long natural history of the cervical cancer. So the malignant transformation of the epithelial cells, cervical epithelial cells after HPV infection occurs over a period of 10 to 20 years. And it is during this period of time that if screening techniques are implemented, screening tests are implemented, these women with precancerous lesions can be detected and invasive cancer development can be prevented in them. So a brief overview of the methods for cervical cancer screening. A variety of methods are available, but the most commonly used ones include visual inspection after application of the acetic acid, cytology, which includes conventional cytology as well as liquid-based cytology, primary HPV testing, and co-testing involving HPV testing as well as cytology. Each of these methods have their own strengths and limitations. Like VIA has a very good sensitivity, but is limited by its specificity. Similarly, cytology is highly specific and economical, but it has moderate sensitivity and is unable to distinguish progressive disease from that destined to regress. Likewise, HPV primary screening has high sensitivity, high negative and positive predictive value, but has relatively lower specificity. However, this one is the most recommended test worldwide. So coming to the topic proper, that is cervical cancer screening guidelines. So a recent systematic review published in June 2021 highlighted that there are 29 published cervical cancer screening guidelines. The basis for majority of these guidelines is derived from the evidence-based randomized control trials, and the recommendations are based on the acceptability, feasibility, equity, affordability, and the benefit to complication ratio of these screening tests. So I will be discussing the FOGSI guidelines, followed by the WHO and the American Cancer Society guidelines. So the FOGSI guidelines, unlike these global guidelines, are very flexible, and they have not laid down stringent or rigid criteria, and most of the recommendations have been derived from the WHO and the ACS guidelines only. So let us begin with the FOGSI recommendations 2019. These were published in the Journal of Obstetrics and Gynecology Research in Feb 2020. And like I said, they are quite flexible, and they say that based on your own available resources, you can decide whether to use cytology as the primary screening modality or primary HPV testing or VIA. And if any of these screening tests comes to be positive, colposcopy and biopsy has to be done and appropriate management has to be chosen. So the recommended approaches are the screen and treat approach, where based on a positive screening test, treatment is administered, and see and treat approach, where in the first setting itself, colposcopy is done and simultaneously treatment is administered to the patient. So based on the resources, the FOGSI recommends that you can use your own HPV, your own screening test like HPV, cytology or VIA. And for resource limited settings, VIA is the preferred modality. So the target age group they recommend is 25 to 65 if you have good resources, while you can start at 30 and continue up to 65 for resource limited settings. For 25 to 30 years age group, they recommend cytology as the preferred modality rather than HPV testing, which is in the rest of the age groups. So when to stop? They say stop at 65 years if women has had consistent negative results in last 15 years. So follow-up after treatment has to be done preferably by HPV testing and has to be done annually, and it should be continued for a minimum of 20 years post-treatment. So for hysterectomized women, they say after hysterectomy, you can stop screening provided the hysterectomy was done for an unrelated cause. And they have also given some recommendations for screening in immunocompromised women. And they say that screening should begin within 1 year of the initiation of the sexual activity. And any of the screening tests can be used depending upon your resources. However, shorter intervals should be preferred of 2 to 3 years. So besides these recommendations, they also provide algorithms where you can decide the management approaches depending upon the primary screening modality used. So like if HPV testing has been used as the primary screening modality, and if it comes out to be positive, then preferably instead of going directly for the treatment, which can also be an acceptable option, then preferably triage should be done by employing another test. Like VIA can be done, cytology can be used, or genotyping can be done. So if any of these VIA or cytology tests comes out to be positive, then this woman has to be administered provided treatment. While if these tests come out to be negative, then repeat testing by HPV has to be done at 1 year. Similarly, if genotyping has been done as a triage after primary HPV screening and women test positive for 16 or 18, then directly you have to provide her treatment. But if she tests positive for other HR-HPV types, then repeat HPV testing has to be done at 1 year interval. So similarly, if cytology is used as the primary screening modality and the result obtained is unsatisfactory severe, so HPV report has to be reviewed if available with that patient, with that female, and if it is positive, then appropriate management according to the previous protocol has to be done. If no report is available, no HPV report is available, and the female is less than 30 years of age, then repeat cytology has to be done within 2 to 4 months. And similarly, VIA can also be employed, and if positive, then VIA management has to be provided to the female. So now, what happens if ASCUS comes out to be the result of cytology screening and the female is more than 30 years of age? So again, triage has to be done. Preferably, triage has to be done by using HPV test or cytology. And if either of these tests is positive, then the female has to be provided with treatment in the form of colposcopy without biopsy. And the biopsy will then guide the treatment, further treatment. And in case of non-compliant patients, direct treatment administration can also be done. So if LCIL is the result of the cytological screening, then triage has to be done by performing HPV test. If the HPV test comes to be negative, then co-testing is recommended at 1 year interval. But if this comes to be positive, then the patient has to be provided colposcopy with or without biopsy, and then that will guide the further management. But for non-compliant females, after a diagnosis, a cytologic diagnosis of LCIL, a direct provision of colposcopy biopsy or treatment can also be done as an acceptable option. So what happens if ASC-H or HCIL is reported on cytology? Then the female has to directly undergo colposcopy with cervical biopsy and endocervical assessment. And if any epithelial abnormality is detected, then the patient should be provided ablative or excisional treatment options. However, if low-grade lesions are detected, then co-testing at 1 year is recommended. So what happens if the female is less than 30 years of age and a cytology diagnosis ASCUS or LCIL? In such cases, repeat cytology annually has to be performed twice for a period of 2 years. And if no epithelial abnormality is detected, then the female returns back to the routine screening. However, if any epithelial abnormality is detected, then colposcopy with or without biopsy has to be performed. Similarly, if ASC-H or HCIL is detected in a female less than 30 years of age, colposcopy with or without biopsy has to be recommended. And if a high-grade lesion is detected, then treatment has to be provided. If no high-grade lesion is detected, then repeat cytology and colposcopy 6 monthly for 2 years is recommended. And if there is persistent ASK-H or HCL for 2 years, then diagnostic excisional procedure has to be performed even if the female is less than 30 years of age. So what happens if atypical endocervical cells, NOS, are diagnosed on cytologic screening? So then colposcopy with or without biopsy, but with endocervical and endometrial sampling has to be performed. So if a high-grade lesion or AIS is detected, then treatment has to be provided. But if no high-grade lesion is detected, then the patient doesn't return back to the normal screening, but a repeat co-testing or cytologic screening at 1 and 2 years interval is performed. And if any of these tests is positive, then then this female is recommended colposcopy with or without biopsy. Similarly, for atypical endometrial cells, endometrial and endocervical curettage has to be performed. If endometrial pathology is detected, appropriate management is given. And if even if no endometrial pathology is detected, then colposcopy with or without biopsy is recommended, so as to exclude other possibilities. So if AGC-FN or adenocarcinoma in situ is diagnosed on cytologic screening, then the female is offered colposcopy with endocervical and endometrial sampling. If endometrial pathology is detected, hysterectomy is provided as an option. Endocervical pathology is detected, then diagnostic excisional procedure like conization has to be performed. But if both are negative and cytology has given a diagnosis of AGC-FN or AIS, then this female has to be evaluated for ovarian, fallopian tubal pathologies. And if any of these is detected, then she has to be treated accordingly. However, even if none of these are detected, then also conization is recommended by FOXI. So, similarly, FOXI has also given guidelines, algorithms for co-testing and VIA screening. So, if VIA test is positive, then the female is offered colposcopy with or without biopsy, or she can be offered treatment directly at the first visit itself. So this brings us to the end of the FOXI guidelines. After that, we'll be discussing the WHO guidelines. So in the WHO guidelines, they've given separate recommendations for HIV positive women and for general population women. This is because HIV positive women are more vulnerable to development of cervical diseases, and they're more likely to have persistent HPV infections with more rapid progression to pre-cancer and cancer, and have a 6-fold higher risk of cervical cancer as compared to the general population women. So WHO recommends that screening should be done by primary HPV DNA detection rather than VIA or cytology. And both self-collected as well as healthcare provided samples are acceptable for HPV testing. However, acceptable alternatives include co-testing, cytology alone, or VIA. So for primary HPV screening, only 2 FDA-approved HPV tests are recommended. That is COBAS HPV and OnClarity HPV. COBAS HPV can detect HPV 16 and 18, while OnClarity can detect 14 HR HPV types, including 16 and 18. However, since these are not available for all these setups, so co-testing with 5 HPV tests is recommended, including these COBAS and OnClarity. There are Aptima, Cervista, and Digene assays that are recommended for co-testing. So WHO recommends to start screening at 30 years in general population. If HPV is used, screening is to be done at 5 to 10 years interval. If cytology or VIA is used, it is to be done at 3 years interval. And either of the screen and treat approaches or screen, triage, and treat approaches can be used in general population women. But for HIV positive women, the starting age is 25 years. Screening intervals are shorter. For HPV, 3 to 5 years interval is recommended. For cytology and VIA, a 3-year interval is recommended. And only screen, triage, and treat approach is recommended for these women. So when to stop screening? WHO 2020 guidelines say that after the age of 50 years, you can stop screening, provided the female has had 2 consecutive negative screening results. However, whenever you have good resources, If a female has never been tested in the age group of 50 to 65, you can continue with screening. So the screening approaches recommended by WHO are screen and treat approach, wherein screening result guides the treatment, and the other one is the screening, triage and treat approach, wherein the treatment is based on the screening and the triage result combined. And the triage modalities can be genotyping, colposcopy, VIA, cytology, or HPV testing, depending upon the primary screening test used. So what is to be done if a positive screening result is there, but the triage test is negative? So WHO says retesting with HPV DNA has to be done. If HPV was the primary screening test, then retesting has to be done after 24 months. If cytology was the primary screening test, then retesting has to be done at 12 months interval. And if any of these comes to be positive, then the female has to be provided treatment. So similarly, for HPV positive women, WHO recommends, irrespective of the primary screening test, whether it was HPV or cytology, retesting has to be done at 12 months interval. Now, what about surveillance after treatment? For general population, women that have been treated after positive screening test or after histologically confirmed high-grade lesions, retesting has to be done at 12 months by HPV DNA. And for HPV positive women, retesting has to be done at 12 and 24 months, again by HPV positive women. So this table lists the WHO summary of the WHO recommendations in general population women as well as women with HIV. These WHO has also given various algorithms for management similar to the FOXY guidelines. So directly screen and treat approach algorithms are also available, and screen, triage and treat approach algorithms are also available. Like here HPV test has been used as the triage, here VIA, here genotyping, cytology or colposcopy has been used as the triage options. So with this we come to the American Cancer Society 2020 guidelines for cervical screening, and they recommend to start screening at 25 years, irrespective of the sexual activity or the vaccination status. And similar guidelines have to be followed for vaccinated women also to date. So ACS recommends that primary HPV testing by using COBAS or OnClarity has to be used as the recommended test. However, acceptable alternatives include co-testing and cytology alone. So regarding screening intervals, they say for primary HPV testing and co-testing, re-screening has to be done after every 5 years. For cytology, it has to be done after every 3 years. So when to stop screening? ACS says after 65 years, if the woman has had adequate negative prior screening, the screening should stop. However, it should be continued after 65 years if there is no documentation of results. So what are the suggestion criteria, or what is this adequate negative prior screening? Screening should stop in a 65-year-old female if she has had 2 consecutive negative HPV test results or co-test results, or 3 consecutive negative cytology test results within the last 10 years, with the most recent test being within 3 to 4 years. So what are the recommendations for management of the positive screening results? So ACS recommends using the ASCCP consensus guidelines for management of the screening abnormalities, and these management guidelines are based on the risk estimates and not the screening results. So risk thresholds are determined based on the current and the past screening results of the female, and the risk estimation tables have already been prepared. They are freely available online. And based on these risk tables, the immediate development as well as the 5-year risk of development of SIN3 is estimated, and this risk guides the further management. So this 4% is the magic figure for the risk stratification according to the ASCCP guidelines, and risk estimation is done based on the current and the past screening results. So, and we determine whether the risk is more than or less than 4%. If it is more than equal to 4%, then colposcopy and expedited treatment are given as the options depending upon the individual risk values. And if it is less than 4%, then we have to assess the 5-year risk of SIN3 development. And depending upon the individual risk values, the female is then called for rescreening in 1, 3, and 5 years intervals. So this figure also shows the same. This is just to highlight some examples, like if a female has ascus and her screening result was HPV negative, so she has a 0.4% risk of SIN3 development. So she is called for rescreening in 3 years. However, if the present result is ascus but her previous result was HPV positive, then the risk becomes 4.5% and colposcopy is immediately recommended in her. Similarly, for HPV negative HCL, HPV positive HCL, the risk values are significantly different. And if the female has HPV 16 positive HCL, then the risk value is 60% and expedited treatment is directly recommended in that female. So lastly, for the post-treatment surveillance, ASC recommends continued surveillance for at least 25 years. If HPV testing or co-testing is used, surveillance has to be done after every 3 years, and it has to be done annually if cytology is used. So lastly, I would like to summarize the main guidelines, main recommendations of these guidelines. So the management options, they do not differ significantly. However, the American Cancer Society has given the direct recommendations based on the risk-based stratification, which is quite useful. However, in India till date, we are following the FOXI guidelines only, which are quite flexible. So with this, I would like to end my presentation, and I will say that early detection is the best protection. So let us join hands together to fight against the cervical cancer. Thank you.